All right, good morning, everybody. We have sound now. Thank you. Thank you, everyone, for attending this morning. We really appreciate it. This workshop is Cutting Edge Clinical Trials, Insights, and Updates. We have a number of dynamic speakers with very interesting topics, so we're all glad you joined. I am Lisa Bendy. I am the research manager at Indiana University School of Medicine in the Pediatric Pulmonary Department, and this is my co-chair, Jane Gross, at the University of North Carolina at Chapel Hill.
This is our our moderator disclosure. And then we just wanted to highlight some of the goals and objectives today. So we're really aiming to explore recent advancements in clinical research design, implementation, and therapeutic innovation. Our objectives today are to describe recent trends and innovations in clinical trial design and execution, including adaptive and decentralized models. We want to summarize key findings and implications from selected high-impact trials across major therapeutic areas. And then hopefully you will be able to apply this updated knowledge to optimize clinical trial participation, data quality, real-world data, digital tools, and enhancing trial precision and efficiency, as well as patient outcomes.
Okay. All right. Well, these are our speakers that will be presenting this morning. Just to give you a little information about them, and they are in order that they will be presenting. First is Dr. Ezekiel Baran, and he is from Buenos Aires. And so he will be presenting comparative clinical outcomes of Trikafta versus bioequivalent ETI formulations in the management of cystic fibrosis in adults, a real-world experience. Second will be Dr. Marcus Moll from the University in Berlin, Germany. He will present a phase 2 study, I always say this wrong, CLARIFY, evaluating safety, tolerability, pharmacokinetics, and pharmacodynamics of the DPP1 CAT-C inhibitor, BI 1291583, in cystic fibrosis, effects of CFTR modulator therapy use.
Next, we'll have Dr. Jason Maley from Sionna Therapeutics. He'll be going over the safety, tolerability, and pharmacokinetics of novel NBD1 stabilizers called Scion 719 and Scion 451 from 2 phase 1 first-in-human studies. After that, we'll have Dr. Mira Viajan from Stanford, and she'll be talking about nutritional decline and glycemic variability as early clinical indicators in predictive cystic fibrosis patients undergoing CGM, and this is a retrospective cohort analysis.
And last, we will have Dr. Pushpa Kamara, and she is from the University of New South Wales, Sydney, Australia. She will present artificial intelligence integrating gut microbiome, multiomics to predict clinical outcomes in children with cystic fibrosis. All right. All right, and first up is Dr. Baran. Thank you so much.
Just as a reminder, we have 15 minutes per speaker, and we'll have questions immediately following the speaker presentation.
Well, thanks for the presentation and also for being selected to this workshop. This is a comparative clinical outcomes of Trikafta versus bioequivalent ITI formulations in the management of cystic fibrosis in adults. It's a real-world experience, and this work is joined with Betiana Pereira. She's from the Hospital San Roque of Cordoba, Argentina, and also with Maria Gabriela Tupachachi Ortiz. She's from the Miller School of Medicine from Miami, United States. There is nothing to disclose related to this presentation. And the background, Alexacaftor, Tezacaftor, Ivacaftor combination therapy has truly revolutionized the treatment of CS patients. We know that the increased body mass index with the nutritional status, BF, and also the health quality of life. However, the cost of the Trikafta is so expensive and it's a barrier to access. So with the recent introduction of the use of bioequivalent formulations outside the United States, especially Argentina, with Trilexa manufactured by Tutor and Trixacar manufactured by Gador, it is essential to evaluate the real-world effectiveness compared to the original formulation, Trikafta. So it's a gap between physicians, patients, and also healthcare to know if there is is work as well as the original formulation. So today there are no studies comparing. This is the first one in all patients, and the aim of this study is to compare the clinical outcomes between these formulations in all CF patients. We made a prospective observational study comparing 50 adults patients receiving Trikafta with 101 patients receiving bioequivalent formulation, either Trilexa or Trixacar. Perhaps I said either Trilexa or Trixacar, perhaps the same patients one month receives Trilexa and the other Trixacar. We don't know which one. I'll talk later about that. The parameters evaluated included were FE1, body mass index, exacerbation frequency, but the severe ones with intravenous antibiotic courses per year, adverse effects, treatment discontinuation rates. The clinical outcomes were assessed at the clinical evaluation before starting ITI therapy, that's at the baseline, and then at the first clinical evaluation 6 months later after initiations. We use 6 months because it's a plateau. Some published data says that the first 48 hours, 72 hours, the modulator is activating and start doing mucus clearance. But it's a plateau between 1 to 3 months. So it was a more statistical difference if we use 6 months. These are the centers where involucrated. There is in Miami Hospital, in Miami School of Medicine, it was 50 patients with Trixacar, and in Cordoba, Argentina, and Rossi Hospital. In Cordoba, there were 43 patients, and in La Plata, 48 patients with bioequivalence. These are the bioequivalence study with Trixacar and Trilexa. You can see Elexacaftor, Tesacaftor, Ivacaftor curves of formulations. We have a regulatory agency that is called ANMAT. It's like FDA and the EMA. And this is critical, is a strategies for access. There is a regulation in Argentina that everyone, it was up to 2022, and incorporates at the Universal Protected Health Technology of the National Program for Monitoring Protected Health Technologies, either original or bioequivalent. Is by law, everyone who is eligible to get the modulator, they must take it. The results of the baseline characteristics was age, gender, F508del mutations or other mutations. These are what we found for the baseline. The age was 39 versus 30 years old, Female 50 and 48, it was similar. And F508del homozygous 40 versus 37. Heterozygous 52 to 51, and other mutations 8 versus 13%. And class 1 mutation, that is important because we must compare both original and bioequivalent, was 18 versus 15. None of them with P significant, except of the age. The group of Trikafta was older. We think that it was because they start first with the modulator in the 2019, and later the bioequivalence appear in Argentina. The baseline characteristics was FP1, percentage of FP1. The severe patients were, the FP1 was less than 30%. Body mass index and intravenous antibiotic courses per year per person. The Trikafta group was 2.15 versus Trilexa Trixacar group 2.29. The median, both of them were with moderate lung affection, and severe was 10 to 8. Body mass index was a bit higher in the Trikafta group, and intravenous also were more in the Trikafta group. It was not significant, the difference between intravenous antibiotic, but almost there. Post-triple combination, both groups reached 2.59, but the Trikafta group, like the slide before, it was a little lower. And the percentage was 61 to 72. The body mass index, there were almost a difference significant. And intravenous courses of antibiotics was 0.18 to 0.14. The absolute change, that is the most important, found, it was really similar in both groups. FB1 0.21 to 0.3, with no significant changes. The percentage was a delta of 6.4 versus 8.8, and the body mass index was 9.6 to 1. And the intravenous, yes, it was a statistical difference. What is important also when we are looking for formulations or new formulations is the adverse effects and adverse effects. There was cutaneous, gastrointestinal, mental health, testicular pain, stop medications, and in the adverse effects, disease and unplanned pregnancies. So the adverse effects were similar in both groups, 20% Trikafta group and 25 in the Trikafta group. Cutaneous was 1 patient in the Trikafta, 8 in bioequivalence group, gastrointestinal 3 to 8, and mental health that first of when it started to dispose the medication, it was not so common, but later we see that it was really common. It was 6 in the Trikafta group and 5 in the Trikafta group. Testicular pain, that it was not so common. Also in our group we had 3 patients, and in the Trikafta 1 patient, and 1 stop medication. In adverse effects, unplanned pregnancy, it was 1 in Trikafta, 2 in Trikafta, so it's recommended to get issues about labor in people who use modulators, and this was 1 each group. To conclude, there are similar efficacy and adverse effects in both groups. There are clinical benefits in bioequivalence, similar improvements in pulmonary function parameters and adverse effect profiles in both groups. And the original formulation was associated with less exacerbation requiring EV antibiotics. We think that it's because of COVID pandemic and the quarantine, because when overall exacerbation decreased during quarantine. And in real-world settings, bioequivalence ITI formulations offer similar efficacy as the original 81 formulations. Before I conclude, I want to thank our groups who made this work incredible. It's the Rossi Hospital, Miami Hospital, and San Roque Hospital. And I think that regardless of the medication, everyone, we are part of the CF community, and everyone, regardless where they live or where the economic status, everyone must have the medication. And thank you for your attention. I am waiting for questions. Thanks.
We invite any questions to people with questions to come to the podium. Please introduce yourself, and thank you.
Oh.
I don't think that one's on. There's help on the way.
Here comes Drew.
I couldn't. I don't listen.
We can hear you, so just speak, please.
Hey, don't worry. It's okay.
Well done.
We have time.
They cancelled the run. It was meant to be a run, a 6K run in the morning. Michael Bolshansky, Jerusalem. I just want to know, in the centers you had, were the drug administered, both drugs in each center, or?
No,
That is a major problem.
yeah, it's like that. In Miami center, they use Trikafta, and in Argentinian centers, we use Trilexa or Trixacar. But what I want to say is that perhaps the same patient, 1 month get Trikafta, and the other month perhaps takes Trixacar. So, Trilexa, sorry. So we cannot know which patient was which each drug, or each formulation, sorry. This was because of our regulation law, so the ministry bought the cheaper one.
I've got a question. Can you comment on how people access the biosimilars and potentially comment on the cost of that as well?
Sure. People who have social secure gets the medication by the security, and people who doesn't, they take it by the health ministry, and the health ministry takes one or the other. And the other question was?
Cost.
Oh, the cost is the half of the Trikafta. Yeah.
We encourage you to come up for questions. I'll ask one more. Any thoughts of doing the same study in children?
Yesterday they told me that a center of Argentina is doing that. Yeah.
Fantastic.
Oh, yeah.
I have a, hello, can you hear me? Yes. I think my question is more in regards to accessibility for the rest of Latin American countries to the bioequivalent version that's available in Argentina. Like, is there a program in place that could facilitate for, patients in other Latin American countries to get this medication, the bioequivalent medications?
I couldn't get you correctly what you say.
Okay. If there is any program, is there any program in place in Argentina that will allow for other Latin American patients to get the bioequivalent versions of Trikafta from Argentina? Well,
first of, when they started in the 2090s, we have Trikafta, but we have to send lots of papers to the regulation agency, that is UNMAT, and they bring us the modulations. Later, in the 2022, we start having bioequivalence. So at that moment, they started bring us the bioequivalence. Is that what you?
No. Okay. My question is, these bioequivalent medications are only available for people in Argentina. Is that correct?
No.
No. Okay.
Some medications are going to South Africa, I know, and in Asia, they were in Kazakhstan, I know. A year later or 2 years later, they were Trilexa there.
Okay. And is there any particular program in place that would facilitate, from people from other countries in Latin America, neighboring countries like Chile, Paraguay, etc., to get this medication from Argentina?
I know that people came to Argentina to buy it and then bring it them.
Okay. Because I think you mentioned Social Security.
And also in South Africa, they use clarithromycin to expand it, the lungs of the formulation.
Oh.
They use it 3 times weekly, and they use clarithromycin to expand it.
Oh, okay. Thank you.
You're welcome.
Just want to remind you can enter questions on the app as well if you're not inclined to come up to the microphone. Thank you, Dr. Baran.
All right. And next we have Dr. Marcus Small. Thank you.
Yeah, thank you for the opportunity to present the phase 2 Clarify study on a new DPP1 or cathepsin C inhibitor verducatab in cystic fibrosis, and the results of the entire study population have already been presented at the European CF meeting earlier this year. So the focus of this presentation and analysis is now on the effects in patients with and without CFTR modulator use, and this was specifically ETI. So here are my disclosures, and the overall objective of the Clarify trial was to investigate the safety, tolerability, pharmacokinetics, and pharmacodynamics of this new DPP1 or cathepsin C inhibitor verducatab in people with cystic fibrosis and bronchiectasis. And as I said, the focus of this presentation now is to look at the subgroup analysis of patients who were treated with CFTR modulators and those without CFTR modulators. So as you all know, bronchiectasis is an almost invariable feature of cystic fibrosis lung disease, and it's characterized by chronic neutrophilic inflammation. And a key feature of this chronic neutrophilic inflammation is increased activity of neutrophil serine proteases. The best known is neutrophil elastase, or NE, but there are two more, cathepsin G and proteinase 3, and they really overwhelm the anti-proteases and the protease-anti-protease balance in the lung, and this protease burden really plays a key role in promoting the muco-inflammatory environment in the CF lung. So, and again, given that all three NSPs are activated by DPP1, inhibition of DPP1 is a promising target to reduce these damaging effects of neutrophilic inflammation in bronchiectasis. There has been a phase 2 study in non-CF bronchiectasis with this compound, the AirLeaf study, where it showed that this novel DPP1 inhibitor reduces the risk of pulmonary exacerbations in adults with non-CF bronchiectasis. And when we looked at the entire study population of the phase 2 CF trial, the Clarify trial, and compared it to the AirLeaf trial, we found that the PK and PD of verducatab overall is similar in people with CF and non-CF bronchiectasis. Now, despite the recent label expansions for CFTR modulators, we estimate that approximately 10 to 15% of people with CF cannot benefit from modulators, either because they are ineligible or intolerant. We also know that people treated with modulators can still experience pulmonary exacerbations. And additionally, from several observational studies, we have seen data now showing that the levels of free NE activity can remain increased and persist on CFTR modulator therapy. So in this context, the effects of CFTR modulators on the verducatab safety, exposure, and neutrophil elastase inhibition in CF are unknown. This is obviously important when you think about developing such a DPP1 inhibitor for cystic fibrosis in the future. And this was the aim of the study, to investigate safety, tolerability, PK, and PD in participants with and without CFTR modulator use. So briefly, I want to go back to the study design here. So Clarify was a double-blind, placebo-controlled study with 2-to-1 randomization to verducatab as a concentration of 5 milligrams and placebo for a duration of 12 weeks and a 4-week follow-up. And the key inclusion criteria were adults with cystic fibrosis, with CT confirmed bronchiectasis, who were current sputum producers and had a relatively high symptom burden, either 2 exacerbations in the previous year or 1 exacerbation with a St. George's respiratory questionnaire, symptom score greater than 40 at screening. And this was done on purpose because these were also the inclusion criteria of the Airleaf non-CF bronchiectasis trial. And then key exclusion criteria, pretty standard, moderate to severe lung disease, neutropenia, or evidence of impaired renal function. So the primary endpoint of the trial was the occurrence of treatment emergent adverse events up to week 16, and then secondary endpoints were the PK and the PD, assessed based on the change in sputum neutrophil elastase activity from baseline. And here you can see the baseline characteristics of the study population, split up by CFTR modulator use. And what you can see is it was a small study, a profiling study with 22 participants that were randomized for verducatab. And you can also see that 50% of the overall population were on stable CFTR modulators, and the other half was not. And looking at the baseline characteristics, you can also see that they were similar across these 4 groups. Now, when we look at the safety, and again, we have to, when we interpret this data, we have to think that it is a very small study, but the treatment emergent AE frequency was similar across the treatment groups, irrespective of CFTR modulator use, and this included any adverse events as well as serious adverse events, which were mainly pulmonary exacerbations. I want to spend a minute on the potentially mode of action related adverse events informed by a rare genetic disease called Papillon-Lefèvre syndrome. And this is a disease where patients have a loss of function mutation in cathepsin C or DPP1, so they cannot make this enzyme. And interestingly, they do not develop severe immunodeficiency, but they can develop severe periodontal disease and skin abnormalities. These were also observed here in individual patients on the 5 milligram verducatab dose, but with respect to severity at much lower levels or less severe than what is seen in Papillon-Lefèvre syndrome. Now, pharmacokinetics. I already mentioned that the trough plasma concentrations of verducatab in the overall CF compared to the non-CF bronchiectasis cohort were similar. And the same is observed here when we now zoom in into the CF cohort and compare with modulator use and without CFTR modulators. It was also not expected that there could be differences, but this is obviously a sort of a data-based confirmation that there's no relevant drug-drug interaction between CFTR modulators and this DPP1 inhibitor, which is obviously also important for further clinical development. And then, importantly, the pharmacokinetics, and what you can see here are the baseline sputum NE activity grouped by CFTR modulator use. And I want to point out 2 things here. First, that the baseline sputum NE activity is actually pretty high in both groups, with and without modulators. and in a similar range to the baseline NE activity reported in the AIRLEAF study. And at the bottom, you can also see the range that was observed in the AIRLEAF study. So this is really similar range that was previously observed in non-CF bronchiectasis with a high symptom burden. And then second, you can also see that there's a trend towards higher baseline levels in patients that are not on CFTR modulator treatment. And I think this is consistent with what we are now also seeing in several observational studies. And then the inhibition of neutrophil elastase activity relative to baseline according to the two groups. And you can see that patients on CFTR modulator therapy or in patients on CFTR modulators, there was a consistent and high, above 90% inhibition of free neutrophil elastase activity in the sputum, but in the verducative 5 milligram group, but not in the placebo group. And when we look at the group of patients that were not on modulators, can still see a robust inhibition of neutrophil elastase at somewhat lower levels. And interestingly, we also observed even an increase in neutrophil elastase activity during the duration of the trial in the placebo group. So in summary, there are no notable differences in the adverse event profile or pharmacokinetics observed with verducative in people with CF who receive CFTR modulators or are not on modulator therapy. Interestingly, in this population with a history of pulmonary exacerbations and high symptom burden, the baseline sputum and E activity was elevated irrespective of CFTR modulator therapy, and sputum and E activity was reduced for people with CF with and without CFTR modulators, with a potential for greater effect relative to baseline in people on CFTR modulators. And I think this is important because it suggests that there is still a need for additional treatment options to control inflammation in people with CF on modulators who still experience pulmonary exacerbations and other symptoms. And the phase 3 activity study of verducative that has started earlier this year is now for the first time including people with CF to assess the efficacy, safety, and tolerability of verducative as a new anti-inflammatory in people with bronchiectasis, regardless of the underlying etiology. And you're also welcome to come to the poster on the activity study that will also be presented this afternoon. And I'll stop here. I want to thank all the co-authors, the clinical study teams, Boehringer Ingelheim as the sponsor for this study, and I'll thank you for your attention. Be happy to take questions.
Dr. Olivier, go ahead.
Marcus, that was a great presentation. I know it's always difficult to explain what goes on in a placebo group, but there was about 30% inhibition on the latter two measurement points in the placebo group, and I was wondering if you had any ideas why that may be.
It's very hard to understand. Up here, the acoustics are bad on this end. Can you talk slower, possibly?
Yeah,
and I think we can hear it.
I was wondering
So
about...
we're going to, sorry, can you hold just 1 second? It's actually going to be easier if we walk down and we listen from the speaker and then come back up, but they're just going to do their side talk. Sorry, it's completely inaudible sitting up here.
Okay, so the question was, what is going on in the placebo group, where there was also an inhibition of up to 30% in the patients who were on modulators? So I pointed out that there was a further increase in NE activity in the patients that were not on modulators. But this is a good question. And so my interpretation would be that this is a result of a controlled trial that not only tests the effect of the new drug, but also follows the patient more closely, which will probably also result in more intense, following of the other therapies. A nice example of how a clinical trial can help to improve treatment adherence, as a speculation.
Dr. Rajan.
I think it's easier. Oops, this works. Yeah, I think it's we had this same issue in the previous session. It's really unfortunate. So my understanding of Papillon-Lefebvre syndrome, and I have no personal experience with that, is that it develops slowly over time. So how long of an exposure is from NCF or non-CF is available at this point in time to look at the cumulative effect over time for these side effects for teeth and skin?
Yes. Yeah, so that is a very good question. So the CF exposure is very limited, as you could see here, to 12 weeks. For non-CF bronchiectasis, there's an open-label extension trial currently for the AirLeaf study, which is called the AirLeaf trial. And there, it should be up to 2 years now. What I have learned from the phase 2 AirLeaf trial, where we looked very carefully at these, at these issues from the dentists, is that periodontitis can also start very early in the affected children with Papillon-Lefebvre. I think the key is that Papillon-Lefebvre is a loss of function, with zero function, whereas here, we have with a 5 milligram up to 90, in the 90% range. So this is not complete loss of function for one. And the activity trial is also going forward with a lower dose, with a 2.5 milligrams that had less of these potentially treatment-associated side effects in the non-CF bronchiectasis study. Thank you.
I'll ask one question. You did comment that the population selected for is a sicker population that has well-established bronchiectasis. Can you postulate how this might or might not benefit people before bronchiectasis develops, especially in the setting of cystic fibrosis, where we know this is a slow progression over time?
Yes, so, regarding the first part, I think that many of our patients from adolescent age onwards already have bronchiectasis. And then the second part goes to sort of me as a pediatric pulmonologist, and also from the studies of the Arrest CF group in Australia. We know that neutrophil elastase is a key driver and risk factor for bronchiectasis very early on. So they looked at this in their cohort of babies that were identified by newborn screening and found that increased NE activity there is already a main risk factor in the first year of life. So from this perspective, I think I would see this in the future as something that could also or should also be trialed as a preventive strategy. But that's looking into the future.
Right. Thank you. That's exactly what I was getting at. Any other questions from the audience? Okay. Thank you very much.
And just as a reminder, this session is being recorded and it will be on the CF YouTube channel if you would like to watch it again. And next up is Dr. Maley.
Great. Thanks. Good morning, everyone. Thanks for joining, and thanks to the co-chairs for having me join today. Today, I'm going to talk about two of our phase 1 studies, which looked at the safety, tolerability, and PK of novel NBD1 stabilizers, Scion 719 and Scion 451. These are the disclosures. So there have been major treatment advances, of course, in modulators, but there's still a high unmet need in CF in people, including those eligible for modulators. There's a need potentially for more efficacious treatments, potential better safety and tolerability profiles, and improved options and access. And as an example of one unmet need, this is showing data from CHECK-SC on sweat chloride pre and post modulator. So if you direct your attention to the ETI group on the right, in the blue, these are people's sweat chloride pre-modulator, and the same individuals in black post-modulator. Similar to what we see in trials, both for ETI and the Vanza triple VTD. Median sweat chloride here for ETI is 45. There's a significant group above that, including those above 60. And in both trials of VTD and ETI in the real world data, about 2/3 of people don't have normal CFTR function on modulators as measured by a sweat chloride less than 30. And we believe NBD1 stabilizers are really a key to potentially addressing this need to improve CFTR function beyond what's been achieved so far. This is leveraging over 15 years of research, countless people and effort to develop this, including support by the CFF, Genzyme, and Sanofi. And as some background, the F508del defect resides within the NBD1 domain of CFTR. And as a result, it destabilizes this domain and prevents normal trafficking, domain assembly, half-life of CFTR at the cell membrane, and ultimately function of CFTR. Our NBD1 stabilizers are the first and only small molecules that directly bind to and stabilize NBD1, and in combination with other complementary modulators, have the potential to fully normalize CFTR function. And I'll show here some of the complementary modulators directed at other regions that we have, including the transmembrane domain and the fourth intracellular loop of CFTR. So these were two phase 1 healthy volunteer studies. They looked at the safety, tolerability, and PK of both of these compounds, 719 and 451. They were randomized, double-blind, and placebo-controlled, and we put 6 participants in each dose level onto active treatment and 2 on placebo. There were single dosing portions, single ascending dose, and multiple dosing portions, or MAD, and the MAD was 10 days long, twice daily dosing. We also had a part C of the study where we looked at fed state and fasted state, as well as tablet versus suspension. You can see for 719 in the SAD and MAD, we dosed from 20 milligrams up to 160 milligrams. And for 451 in the SAD, we dosed from 25 up to 450, and in the MAD, 25 to 300 milligrams twice daily. This is just to give you a sense of the scheme, which is typical for phase 1 studies, a stepwise escalation in dose, crossing then into the start of the part B, which was our 10-day multiple dosing study, and then finally part C, which was the food effect and bioequivalence. So I'll show first the data for 719, and then we'll show the same set of data for 451. I'll orient you some, and then you'll see the same set of slides as well for 451. So 719 was generally safe and well tolerated. This is the data from the MAD safety summary, adverse events across all dosing groups. The SAD and the MAD had an overall consistent safety profile. There were no serious adverse events. All TEAEs, treatment emergent adverse events, were mild to moderate. None led to discontinuation of the drug or limited dose escalation. There were no TEAEs related to elevated liver enzymes and no other clinically meaningful trends in evaluation of participants on exams, safety parameters, vital signs, ECGs, or other assessments. This is the PK, which is showing in this figure the day 10 steady state PK for 719. So this would be people having received in the multiple dosing study 10 days of twice daily dosing. On day 10, we only give a morning dose. We don't give an evening dose. So we can measure the PK, the concentration of drug over time after that single morning dose at steady state. And this is going out to 36 hours, and it's on a log scale on the y-axis. The dotted lines to orient you, and you'll see these for 451 as well, are our concentration targets based on our CF human bronchial epithelial cell assay. So this lower line marked add-on is the predicted concentration to potentially provide clinically meaningful benefit over existing modulators when it's used as 719 plus ETI, so as an add-on to background ETI. The dual combination dashed line going across above that is the predicted concentration of drug needed as a novel two-drug combination to provide potentially clinically meaningful benefit over existing modulators. So that would be, for example, 719 plus a single other complementary modulator. The takeaway for this is that the add-on target was covered at all of the doses we studied. We exceeded the concentration target. And at doses of 40 milligrams twice daily and above, we met our dual combination target concentration. Because of the higher potency of 719, including at a low dose, this makes a good combination potentially as an add-on, and we'll talk about that a bit later. Also, the food effect bioequivalence study showed that we can use this as a tablet, and it can either be dosed in a fed or a fasted state. This is then to bring this together into our CFHBE assay data. This is showing on the vertical scale the CFTR function, and numerically this is relative to ETI. So ETI is at 1, and the black dots are where other modulators, existing modulators, fall relative to ETI in their impact in this assay on CFTR function. The red zone, based on our exposures of 719 in this study, are where a low dose of 719 plus ETI falls in this assay. So the lower end is a minimally clinically meaningful improvement of 10 millimoles of sweat chloride or 3% predicted FEV1. And this ranges in the assay results into potential wild type CFTR function or normal CFTR function. Now, similar data, now showing the same set of slides, but for 451. So we have the summary table of the multiple dosing study, 10 days twice daily across all dose levels tested. 451 was generally safe and well tolerated. The SAD and MAD had consistent safety profiles. There were no serious adverse events, and most adverse events were mild to moderate. None led to discontinuation of the drug or were dose limiting. The only participant who had a TEAE related to elevated liver enzymes had that concurrent with acute influenza, and that was transient and resolved. That same participant had a drop in their neutrophil count, which was also transient and resolved and happened with their influenza. There were no other clinically meaningful trends in other safety labs, parameters, ECGs, vital signs, or exams. So the same day 10 PK now being shown for 451. This is after 10 days, twice daily dosing. We give a morning dose. There's no evening dose, and we measure the drug concentrations. The same targets are shown, but this is now based on our predictions from the CFHBE assay for 451, either when used as an add-on to ETI or standard of care, or used as a novel two-drug combination of 451 plus one other complementary modulator. So you can see that the dual combination target coverage, it was covered at doses of 75 milligrams twice daily and above. The add-on target was covered at all of the doses tested. Because of the high exposures that we achieved at the higher doses of 451, this makes it good as a potential novel dual combination piece of that dual combination. And the food effect part C showed that we can give this either in a fed or a fasted state, and it can be given as a tablet. So these are the CFHBE data, again, looking at CFTR function on the vertical scale relative numerically to ETI here at 1. similar to what was seen for 719 when we use 451 in this assay, either in combination with Scion 2222, which is a TMD directed at the transmembrane domain, or Scion 451 plus Scion 109, which is an ICL4-directed modulator. We see the lower end of the result on the assay is minimally clinically meaningful improvement of 10 millimoles of sweat chloride or 3% predicted FEV1. And this ranges on the assay into potential wild type or normal CFTR function. So bringing this together, our vision and what we've initiated now are these two pathways. First is the study Precision CF, which is our add-on study of a low dose of 719 plus ETI. It's a randomized, double-blind, placebo-controlled crossover trial, and this has now been initiated. We're showing also the dual combination development, which is really our prioritized path because we want to bring a new, truly different dual combination option for patients. And this is currently in phase 1 in healthy volunteers, where we're now testing 451 plus 109 and separately 451 plus 2222 as this novel dual combination, which will then move into people with CF. So in conclusion, these novel NBD1 stabilizers 451 and 719 were generally safe and well tolerated in these healthy adults. And both compounds exceeded the concentrations based on our CF-HBE assay to potentially deliver clinically meaningful benefit over existing treatments. And that could be, for example, when 719 is added to existing standard of care, or when 451 is used as a novel two-drug combination with another complementary modulator. Both can be dosed either in the fed or the fasted state. And so we've advanced these into 2 studies ongoing now and with readouts expected mid-next year, Precision CF, the phase 2A, and the phase 1 dual combination. And we have posters. Poster 107 is based on these data. Poster 303 is from our research team looking at the effect of NBD1 on CFTR half-life. So with that, thanks for joining and listening, and I'll take any questions.
We welcome any questions on the app or at one of the microphones here.
Should I even try?
I would just come up here. Oh. Yeah. Let's go for it. Speak slowly if you don't mind, Kathy.
Very slowly. Can you understand?
Yes.
Yes.
That's great.
Yes.
I'm Kathy Ramos at the University of Washington. Great talk. I'm wondering why you're not going to a triple combination therapy instead of sticking with a dual combination therapy from the start, given the prior experience in, the Vertex modulators that showed triple was so much better than double.
Yeah, thanks for that question, Kathy. So our choice of combinations is really based on our CF-HBE assay data and other complementary assays that predict what we could expect based on these combinations. And that's what we're seeing because of the effect that NBD1 stabilization has on CFTR function. It appears just as a dual combination, which we think is probably optimal relative to adding more drugs from a safety and tolerability perspective. We have the potential to provide that clinically meaningful improvement and also the potential to move into wild-type CFTR function. So that's really why we're taking this next step based on following the data that we have at hand.
I'll just ask a question. What do you see as our potential limitations to using this in larger scale in combination with ETI?
In the ETI combination specifically?
Well, really either group, but yeah.
Yeah, well, I think what we're seeing right now is first just a lot of excitement to have an alternative, but the challenge when you have an existing therapy is also to perform trials we're in a different world than when people with particular combinations of F508del didn't have anything. And so more of the challenge is going to be creating the proper trials that bring patients in, that demonstrate the clinical efficacy and moving forward, but making sure that patients understand the potential benefit of participating.
Hi, Amalia, Seattle. Is anyone who is eligible for ETI also eligible for these studies, or only F508del?
This first study, the precision study I showed, is F508del homozygous participants, and that's really just to have a very a homogeneous group. It's a very small study, and it's a proof of concept. So that's why we have that narrow population. And then as we move forward in development, we expect that we'll be looking outside of that homozygous group.
Okay, thank you.
Thank you.
All right, next we have Dr. Meera Vijayan, and she will be presenting. There you go. Thank you so much.
Hi everyone, my name is Meera Vijayan and I'm from Stanford Children's Hospital, and I'm really happy and excited to be here today to talk about my research that was focused on nutritional decline and glycemic variability as early indicators in pediatric cystic fibrosis in our patients undergoing CGM. This was a retrospective cohort analysis that really hoped to assess a gap in cystic fibrosis care. And I have no disclosures to this presentation. So let's start with why nutrition is so important in cystic fibrosis. As we all know, optimizing nutrition is important for our patients, and there's multiple reasons for that. First, there's a correlation of body mass index and pulmonary function. We also have a high incidence of cystic fibrosis-related diabetes, and there's also enhanced immune function and reduced complications for our patients that have optimized nutrition. It's also important to note that a lot of times, intermittent postprandial hyperglycemia is what we see in our patients. This can be associated with decreases in lung function and heightened airway systemic inflammation. A lot of times, these processes begin even before CFRD is formally diagnosed. Currently, the Cystic Fibrosis Foundation recommends utilizing the oral glucose tolerance test, or OGTT, beginning at 10 years of age. This occurs by having our patients fast prior to clinic, and then we collect a blood glucose level at that time. Then we give them one of these glucose drinks, or glucola, and then take blood glucose samples at different intervals in order to assess their glycemic control. This has proven to be quite difficult for us at our clinic and a kind of logistical nightmare, as a lot of our patients do not tolerate this very well. This is from the CF registry data from last year, where the median of all eligible pediatric programs had 61.5% of their patients undergo an OGTT screening. However, at our center at Stanford University, we only had 53.2% of our patients successfully have an OGTT. There are several reasons for this. This graph is to show our current state at our institution. Importantly, we start our OGTT monitoring at patients of 6 years of age only in the pancreatic insufficient patients. This is primarily due to increased evidence that there's pancreatic dysfunction and glycemic control issues younger than 10 years of age. In 2024, we had 114 patients, where 60% of them were pancreatic insufficient. Of these 68 patients, we had 41% of them undergo an OGTT at 6 years of age. This brings us to our alternative agent, continuous glucose monitors, or CGMs. There are multiple reasons why CGM is important for our patients compared to the OGTT. One, it can capture daily glycemic excursions, which gives us much better data points in order to assess their glycemic control. It can identify brief postprandial spikes and episodes of reactive hypoglycemia, which is what is really our area of interest for our patients. It also can strongly correlate with lung function decline and infection burden. Overall, a CGM provides comprehensive assessment of glycemic variability compared to an OGTT, which is only at the time points in which we get the blood samples, or even a hemoglobin A1C that we use in other forms of diabetes. CGMs provide a lot of data in their comprehensive analysis. Here on the screen, you can see a screenshot of a summary of a CGM that we typically can use to assess our patients. Some of the metrics involved are average glucose, glucose management index, or GMI, which is really an estimate of A1C based on the average CGM glucose. It also provides time in range and the percentage of time our patients are within our target of 70 to 180. It has time above range, where the percentage of time they are above 180 or have hyperglycemia, as well as below goal, less than 70, or hypoglycemia. And for our primary outcome of this study, the coefficient of variability, which is the measure of glucose variability calculated as standard deviation divided by mean glucose. The summary seen here can also be shared with healthcare providers, especially in our endocrine clinic, that are able to assess our patients and make better plans for them. The significance of our study is there has not been a previous study that rigorously quantified whether recent BMI decline can predict CGM-detected variability in children treated with or without modulator therapy. This ultimately led us to our study question: how is the decline in BMI correlated to glycemic coefficient of variability? This was a retrospective cohort study at a single-center children's hospital in pediatric patients less than 21 years of age with the clinically indicated CGM between 2023 and 2025. Our only exclusion was any patients that were on continuous insulin pump therapy. For our primary outcome, we looked at the correlation of change in BMI Z-score and glycemic coefficient of variation within a 3-month time frame. Our secondary outcomes included mean glucose, glycemic management index, time in range, and time above range. For baseline characteristics, we analyzed 35 CGM encounters, with 68 of those patients having pancreatic insufficiency and 71% of them on highly effective modulator therapy. The median age was 15.7 years. It came to no surprise to us that the FEV1 at baseline and at the time of CGM placement was better for our patients on modulator compared to our non-modulator patients, and these were both significant in our baseline findings. They also had better BMI percentiles and Z-scores at baseline and time of CGM placement. Here is our key finding. A clinically meaningful change in BMI was correlated to higher coefficient of variability. This shows that as our patients have an abrupt decline in their BMI, there is more glycemic variability, and it can be triggered to show this. This was both significant in our modulator and non-modulator patients. And this is very similar to the adult data that also described a similar finding. For our total patient cohort, our average glucose was 132 with 26.1% glycemic variability. We also stratified our patients to insulin and non-insulin to see if that made an impact. And you can see here that the average glucose in our patients that are on insulin was 178 with 30.5% glycemic variability, whereas patients with no insulin were 114 with 24.3% glycemic variability. Then we looked at FEV1 and average glucose, and patients that had higher average glucose also correlated with having poor lung function. This was not necessarily a statistically significant finding, but it was for both our modulator and non-modulator patients. Similarly, when we looked at FEV1 and GMI, which again is our estimation of A1C utilizing CGM data, we found a very similar pattern of which a higher GMI was also correlated with poor lung function. This was again not statistically significant, but it was found in both of our cohort patients. And finally, FEV1 and glycemic variability was following the same patterns as all of our other findings. Here we found that higher glycemic variability was also associated with poor lung function, and this shows that how important optimizing our nutrition is for overall patient care in cystic fibrosis. There were several limitations of this study, including having a retrospective design, small sample size, mixed CGM platforms, and a lack of body composition analysis at the time of our study. However, we did find that a clinically recognizable decline in BMI precedes significant increases in CGM-derived glycemic variability, specifically in pediatric cystic fibrosis. So how do we apply this to our patients? CGMs offer a uniform monitoring method and it can really help us to assess glycemic variability and associated BMI changes to serve as a predictive data for decline and begin our interventions early. There are many interventions that we can make, but we hope to increase the frequency of CGM monitoring, intensify caloric density without sacrificing total carbohydrates, optimizing our pancreatic enzyme replacement therapy, as well as initiating any pharmacotherapy for glycemic control if indicated. And these interventions can help us to prevent pulmonary exacerbations and hospitalizations for our patients. At our clinic, we are proposing the following workflow. If a clinically significant BMI decline is seen by our care team, we are able to place a CGM for 10 to 14 days and initiate these early interventions, such as increased monitoring through CGMs, optimizing nutrition and pancreatic replacement therapy, and initiating pharmacotherapy. Of note, our clinic does utilize samples to offer patients, so if they do not have CGMs approved through their insurance, we're able to help with this financial burden and provide this care. In conclusion, short-term BMI decline and diminished lung function within 3 months are early signals of dysglycemia well captured by CGMs. Utilizing a BMI-triggered CGM approach into the standard care of CF could help with timely interventions to preserve pulmonary function. I'd like to take a moment to acknowledge my team, Julie Mattel, our amazing dietitian who helps us monitor all our patients for their BMI and all their optimizations of nutrition, Stella Romero, who is the queen of making sure we get all the CGMs for our patients, Wendy Chin, our nurse coordinator, to make sure that all of this goes smoothly in clinic, Holly Cooper, our endocrinologist who helps us with all of our CF patients, as well as Jake Brockmeyer, my mentor and pharmacist in the CF clinic. Here are my references, and I'm happy to take any questions.
Great talk. We have working microphones now, so please feel free to come up to the microphone. While we're waiting, I can ask a question. I think as a pediatric provider, we recognize the difficulty in getting OGGTs from patients, right? That is a problem for lots of different reasons. Did you assess any, like, the patient satisfaction around doing the CGMs as opposed to having previously done glucose tolerance tests, for example?
We haven't assessed that specifically. However, in a previous study, we tried to utilize OGTT data for similar correlations. And due to the intolerability of those tests, we actually had pretty conclusive data. Holly Cooper, our wonderful endocrinologist, can speak more to what she sees once we have those patients on CGM.
Yeah, so I'm the endocrinologist who sees all these patients, and we don't have data saying that they like it better, but anecdotally, the families are like, man, this is so much easier. Why haven't we just been doing this every year? But we don't have like established cutoffs, consensus cutoffs for CFRD diagnosis with CGM. So it's a thing that is being discussed, and how we can use these to screen people before they have a diagnosis of CFRD is, I think, a hot topic right now.
Great. Yeah.
I'll try again. So this time it might actually work.
Yes.
I saw that you suggested to use BMI decline as your trigger for this. Do you use A1C as at all in terms of your overall assessment of patients? Because you didn't mention that in your talk.
Yes, so if we have A1C data that also goes into a comprehensive analysis of our patients, the real purpose of this study was to show that having a BMI triggered approach can help us to initiate monitoring with the CGM early on. Another future direction of this study is we're trying to use bioelectrical impedance analysis in order to get a more comprehensive and sensitive analysis in order to initiate these interventions early, and that's currently ongoing at our center.
Thank you.
Thank you. Just to continue from Felix's question, because maybe this is kind of where he was going. So there are Canadian CFRD screening guidelines that came out in the last year, and one of the approach the endocrinologists on the committee suggested was using hemoglobin A1C as kind of a cutoff, not diagnostic, and that's been studied and it's not that useful, but people who had very normal A1Cs, not necessarily pushing the 2-hour OGTT, but people who had sort of intermediate and higher OGTTs definitely pushing, and wondered about maybe doing the continuous glucose monitoring for those people instead of pushing the OGTT.
Yeah, so that is really our goal at our center. So the previous study I had was focused on the OGTTs, and when they had differences in their glycemic control, that's when we would send them to the endocrine clinic. And then from there, our endocrinology team was able to assess them, and we do put CGMs on those patients. Again, we have at our center patients starting at 6 years of age on the OGTT to kind of help capture them when they have some of those glycemic variabilities without having an A1C that was technically diagnostic. And from there, we're able to better assess them and hopefully get a good capture on them before CFRD is diagnosed. Yes. And Holly just wants to mention that most of our patients did have an abnormal OGTT, which is why we referred them to her.
Okay, we have a question from the app. Do you have any positive stories where the CGM data led to an intervention on their blood glucose levels and therefore led to weight gain or improved lung function?
I think Julie wants to share a story for this.
I have a really good story. So we had an individual, I think he was at the time an older adolescent, and the family every year refused OGTTs, time and time again. And so we suggested that they try CGM one year, and they agreed. And within a year or two, we noticed like real significant dysglycemia, and that prompted the family to agree to some insulin intervention. So we have really found that when the families can sort of see, sort of in a real life setting, what's happening to glucose homeostasis, that can be propelling. So that was the one story I can think of.
Thanks, Julie.
I'll ask one more question. I know you mentioned access can be a problem to get CGMs for patients. Mm-hmm. I've experienced that in various places too. And you said you had a backup plan for, I think, samples. Was that it? Yeah.
Yeah.
Do you have enough to to take care of the whole population that meets criteria to undergo CGM?
So at our center, we are really lucky to have all the samples that we need for our patients. Our endocrine team works really hard to make sure that we have ample supply. I know this can be a limitation and barrier for other centers where samples are not readily accessible, but trying to promote this kind of work and initiate prior authorizations in order for those patients to receive them can be really important to help with their overall care.
Just to repeat that comment, she said she asked the rep to come by every week. So that's good close contact. Okay, well, thank you very much.
All right, and we have our last presenter today. Thank you, Dr. Pushpa Kumara, and thank you so much.
Good morning, everyone. Thank you so much for this opportunity to present our work at NACFC. So today my talk is on artificial intelligence integrating gut microbiome multiomics to predict clinical outcomes in children with CF. So I'll walk you through why the gut microbiome matters, how it's altered in CF, and how we can use multiomics and machine learning models or artificial intelligence frameworks to better understand these host microbe interactions. Nothing to disclose? All right, start with the basics. So the gut microbiome colonizations begin at birth and continues to early life, and it has important functions in host nutrition and immunity. We know that increased microbial diversity is associated with better health, and early life imbalances in the gut microbiome is associated with high risk of developing inflammatory and metabolic diseases. In CF, the intestinal environment is fundamentally different to that of healthy individuals. We know because of the mutations, there's thick mucus lining, intestinal pH is more acidic, and they are exposed to antibiotics more. So collectively, these physical and chemical changes create a hostile environment for many beneficial bacteria and lead to what we call dysbiosis, simply an imbalance in the gut microbiome. So to understand this complex host microbe interactions, omics offers a powerful technology. So omics is the collective study of biological molecules on a large scale. So we can directly analyze these biological molecules, your RNAs to DNAs. This is culture independent, so you don't have to culture your microbes. You can take your sample, you can extract your DNA, RNA, you can sequence them, and it captures all the microbial communities in the sample. So as a result, it provides a far broader and more inclusive view of the biological system. So there are different types of omics. So I thought I'd go through the major omics types and help you understand what you can study and what insights they provide and what specific questions you can answer using these omics layers. So metagenomics, I think the most popular one. It's the study of all the genomic DNA sequences in the microbial community. It helps you study the taxonomy and the functional potential and helps answer the question, who is in there and what can they do? And metatranscriptomics is the study of RNA transcripts from a microbial community at a given time. It provides insights into active gene expression, and it helps you answer the question, what are they doing right now at the transcription level? Metaproteomics is the study of the entire protein complement expressed by the microbial community, and it provides insights into functional activity, what pathways, what enzymes are activated. And it helps you answer the question, which functions are being executed. So metabolomics is the analysis of small molecule metabolites. It provides insights into phenotypic outcomes and real-time physiological status. So it helps you answer the question, what are the biochemical outcomes? So you can see that if you choose one single omics layer, it can only provide an incomplete picture. But if you connect the dots through multiomics and integration techniques, it helps you to move from a reductionist, one gene, one hypothesis to a more holistic approach. And this also helps to reduce the dimension of the data. At the end, it leads to the identification of a combination of biomarkers as opposed to univariate biomarkers, which can actually provide strong basis for targeted work. So holistic approaches lead to hypothesis generation, which can be taken back into a reductionist approach to more targeted work or targeted interventions. So multiomics generate a large volume of data. It's just not the volume, but it's also a large number of microbial features. So we need tools to make sense of it. Most traditional techniques cannot handle this, and we cannot understand complex patterns. So this is where artificial intelligence or machine learning models comes in. So machine learning model is a core branch of artificial intelligence. Artificial intelligence is basically is focused on making intelligent systems that can think, learn, adapt like humans. So machine learning can investigate and interpret the relationship between your data and clinical phenotypes, and it can mine this hidden information. So there are two major types of machine learning. supervised learning, and unsupervised learning. So in supervised learning, simply your sample is going to be labeled. So you're predicting outcomes using labeled data, and it allows you to do sort of regression analysis or classifications. Unsupervised learning, it's simply you can identify the clusters and patterns in unlabeled data. So the aim of our study is to develop interpretable artificial intelligence frameworks capable of identifying unique gut biomarker signatures arising from microbial multiomics that are associated with clinical phenotypes. So the work and the results that I go through is proof of concept that gut microbial biomarkers can be used to artificial intelligence frameworks can be used to identify microbial features associated with clinical phenotypes. So for the work that I present today, we built artificial intelligence or machine learning models capable of identifying microbial features associated with the disease status, inflammation using M2PK calprotectin stool inflammatory biomarkers, and also growth outcomes using BMI scores. To do this work, we leveraged the PEARL-CF study, which is an international multi-center double-blind randomized placebo-controlled probiotic study comparing 3 cohorts of individuals. We had children with CF all from 0 to 6 years, modulated naive, and the 3 cohorts are children with CF receiving the probiotics, a placebo, and age and gender matched healthy controls. So we have a baseline data, and the study period intervention going for 12 months, and a post-intervention period after the cessation of the probiotic. So if you are keen on learning more about our PEARL-CF study, please visit poster 121. So as outcome measures, we generated multiomics data, metagenomics, both targeted and untargeted metabolomics, and proteomics, we are generating them at the moment. And also other data like fecal calprotectin, M2PK, and clinical data. Okay, so this is the overview of the machine learning platform we'll be using in our work. So there are 3 primary components for this platform. First is omics-specific learning. We use a neural network algorithm called graph convolution networks. So simply for each omics that we produce, we'll be extracting the most important microbial features. And second component, we will be integrating them using another technique to capture and analyze correlations across the omics layers. That'll be helpful in the final predictions. This is not a black box. This has interpretability. We have incorporated SHAP values. Essentially, what it means is this model will tell you what microbial features it used to make the predictions. To do this work, we collaborated with University of New South Wales Biomachine Learning Group, and big thanks to them. All right, let's go through the preliminary results we have. So we were able to build both metagenomics and metabolomics models to identify key microbes and metabolomic features linked to disease status. So we used the baseline data we collected. And for the model development stage, we use 80% of our data for training, 20% for testing. This is all internal validations at the moment. And we were able to build both metabolomic and metagenome models that perform really well. So what you're looking at is 91% and 100% accuracy. So what they mean here is, so these bacterial species we have identified, we see them consistently associated with CF samples. And metabolites, we don't know much about them. So this is what is important. This is what can set the stage for more focused work, and we need to get mechanistic insights. Next, we were also able to build metagenomic model to identify key microbes associated with inflammation. So we use stool inflammatory markers, calprotectin, and M2PK. We stratified our samples to normal and elevated levels. A similar model development stage, 80% training, 20% testing, and we were able to get model accuracy of 80% and 75% for these 2 models. Again, these are potential biomarkers that may be associated with inflammation. Last, we were also able to build metagenomic models associated with BMI scores. So BMI scores, these ranges are the associated with CF. So BMI, we know, has direct association with survival, pulmonary exacerbations, So this gives us some idea about the involvement of bacteria and microbes in growth and survival of children with CF. So similarly, we used a similar model development, 80% training of the data, 20% testing. And we achieved a very high score, that is 88.4% of accuracy of predicting these samples based on microbes. Okay, so in conclusion, our work shows that artificial intelligence frameworks has a significant potential for identifying gut microbiome signatures linked to clinical phenotypes. This work is ongoing. So the candidate biomarkers that we have identified and we will identify in the future, we are working on answering very specific questions, and we've done the proof of concepts and we have built the model. So we are working on extending our data and also extending the clinical questions thereafter. We think that they can help guide future microbiome targeted intervention and provide new mechanistic insights. So we envision that these predictive models developed with AI can be a decision support tool for clinicians in detecting at-risk children early, promoting timely interventions to reduce malnutrition and poor growth. These are my references. And thank you so much for the post-CF team, University of New South Wales Biomachine Learning Group, and the funding, Special CFF Foundation and other entities, and CF patients and families. And a massive thank you from the UI Lab. Thank you.
Is this one working? Can I start?
Yep, go ahead.
Hi. I'm Amalia, Seattle. I just wanted to say how cool that was. I was so impressed because all the different, and that was the best slide I've ever seen on omics, but all the different ways you're looking at bacteria, all the different processes you're looking at, that controls the false negative rate. And then all the different, the cross-validation you're doing controls the false positive rate. It's just beautiful. Just thank you.
Thank you so much.
Go ahead.
Okay. Hi, thanks. I'm Dean Madden from Dartmouth. I really enjoyed your talk as well. Very clearly presented for a non-AI person. I was curious at looking at the signals that you were getting, if you're correlating, as a ground truth, sort of correlating them versus differences in gut microbiome signatures that have been found by sort of traditional methods. I'm thinking specifically of B. fragilis and some of the other gut microbes that have been implicated in various outcomes. Some of them I saw, some of them I didn't, and I was just curious to what extent you're kind of trying to use that as cross-validation for the outputs.
That's a great question. So what I showed you was the most important features, the top two, but it's not just one or two. The model is going to identify up to 10, 20. It's for us to cross-validate and also check the robustness of the model. So once we build the integration, when you move to the integration part of the model, we will do cross-validations and also check the robustness of the model by removing these features and then re-evaluating the accuracy. So we know we can be really sure that these are the biomarker panels that we can, take further ahead and do more targeted work.
Zachary Sellers, very nice work, and I think there's going to be some interesting things that are going to come out of this. I guess question, I think, so right now, it looks like to start with, right, you've established people with certain states, elevated fecal calprotectin, elevated or not. Have you looked at or have you thought to look at sort of dynamic changes over time and how people get to certain states, for example, normal to elevated calprotectin and what that does over time, and those that have changing values and what those signatures may be and what that may be able to tell you about their disease states and or how you may be able to predict when you may want to intervene or not?
Yes, we have. So for the proof of concept work that we did, we used baseline data. We have longitudinal data, and at the moment we have a large volume of data with us. So we are going to extend the work to longitudinal work to make real predictions. Yes.
Very good, thanks.
I have to say that table you showed, breaking down the various definitions was excellent, like Amalia said. You should use that a lot in the future. I guess I have a question. You're talking about using this as predictive models. Are you thinking for things specific to CF or more relatively specific to CF, like small bowel intestinal overgrowth and, anticipating somebody developing obstruction or, things like that?
We haven't thought about those specific things, but thanks for that point. I think at the moment we've got a few other more like on prebiotics, predictions, etc. But definitely we would like to extend it to make it more predictions using those clinical data. Yeah. Sure.
Any other questions from the audience? Okay. Well, thank you very much.
Thank you so much.
All right, and thank you everyone for attending today. We do ask if you please fill out the response survey just for feedback on this session. I think it was a fantastic session, and I want to thank the speakers again all for your contribution. I really appreciate everything you're doing, and I hope everyone has a great rest of your day. Thank you.